So under tylerblack.com/FM, you can actually find this presentation. You can just download the presentation right here, and there's also some other links about suicide risk assessment that I thought would be helpful for you. So for the compulsive note takers in the room, continue to do what you do. For everyone else, you can watch. Okay. So thank you for the introduction, and thanks for having me. I'm always excited when I can talk about suicide risk assessment to people that aren't psychiatrists, and I'll explain why I'm specifically excited about that. I'm required to show you slides on disclosures, and they're going to go really quickly because I don't have any disclosures to make. I don't work for any organizations that have commercial interests, and I mitigate my bias by not participating in all that. Okay, so what I'd like to do is talk to you a little bit about the evidence in youth suicide, and with the proviso that this is not evidence-based suicide risk assessment. I went to a lecture at the APA when I was in my third year of residency on evidence-based suicide risk assessment. At the end of that lecture, the very, very esteemed suicidologist said, so at the end of the day, you have to use your judgment. And I was the only one that put up my hand and said, excuse me, I'm curious why you titled this evidence-based suicide risk assessment when you tell me to use my judgment. And he stammered and stuttered, and everyone went ooh and ah. And the reality is there is no evidence-based suicide risk assessment. You use the evidence because evidence can tell us what risk factors are. In terms of predicting who's going to die by suicide, we have no such requirement or ability. I'm going to talk a little bit about screening for suicide, and this is something where I'm most excited to talk to a group of family practitioners about because screening for suicide, I'm going to show you why you should be screening every person you see over the age of 10 for suicide for the rest of your life. And if you don't do that, I think you're sort of burying your head in the sand. Assessing suicide risk. The worst thing I see in assessing suicide risk is patient denies suicidality, period. Because it makes a very complex thing seem very simple. Something that is very complex, like assessing suicide risk, cannot be done simply. So I'm going to talk a little bit about using what we know about suicide to assess it. So if you ever went to medical school, you might have seen SAD persons. It was developed in 1996, I think, or so, for medical students. And it's been modified to a scale. And the first thing I want to say about SAD persons is horrible. It's absolutely ridiculous. There is no reason to use SAD persons. The only good thing about SAD persons is it's a nice mnemonic to remember some of the risk factors for suicide. So if you want to use it as a memory tool to remember what some of the risk factors are, go ahead and use SAD persons. If you want to try and use this or teach this as something you use to assess suicide risk, the statistics I show you are going to show you, just talk about specifically how silly SAD persons is. So how important is suicide? Well, it's this important. These are the number of deaths between the ages of 10 and 24 in youth for all different causes. And you can see that I've stacked the top 5 medical causes on top of each other, and then I've put suicide right next to this. This is combining the US and Canadian data. It wouldn't make a difference if I selected just the US or just Canada. It's the same in both countries. Suicide is more important and kills more people than cancer, heart disease, lung disease, blood disease, and infections combined. So this is a very, very, very big deal. If you're at all interested in children not dying, you should be very interested in suicide. Now, some people when I present this say, well, you know, you're taking 10 to 24, and most people who die in early age, if you're going to include 1 to 10, you might see a change. Actually, if I gave those other things the advantage of going 1 to 10, suicide would still have the lead. So suicide starts later. But it certainly has the most importance in terms of death. Yeah?
I'm sorry to interrupt you, but I had in my head that the highest cause of death in this age group was accident.
Yes.
So where does that fit?
Way higher.
Okay.
So this would be about, this is about 52,000. So suicides is about 52,000 in the last decade in North America. Accidents would be about 160,000.
Thank you.
So it's not even close. Not even close. So when I talk about suicide, it's a big deal. It's more important than every medical illness we worry about, and in fact, most of the medical illnesses combined, but accidents still number 1.
Okay.
So when we think about funding and dollars and research and efforts and things like that, primary prevention of accidents, reduction of suicide risks would be like curing cancer, heart disease, all these things in kids. It would be the equivalent thing. Another myth that I want to quickly dispel about SAD persons and what you might hear about suicide is that age is related to suicide. I want you to find me someone over the age of 10 where if they came to you saying, I'm suicidal, that you should say, I'm not as worried because they're a certain age. Look at that graph. That's Canadian data. I pull this every year. I pulled it together. I put it together. There's never a time, 90-year-old male, fairly low in terms of the peaks, but if they came to me saying I'm thinking of dying by suicide, I'm still going to worry about it. Suicide risk starts at age 10. It continues throughout life. And there is no relationship between age, except you can deface all of your textbooks from now on. If you ever see age and sex listed as criteria, just draw an arrow from age and put it to sex. Because age is a risk factor if you're a male. It is not a risk factor if you're female. And I pull this every year from Stats Canada. This has never not been true. So whatever statistics people were using to write these textbooks, they were not looking at the numbers that they had. They were just simply presenting things. I don't know why they would do that. But histograms and things like this, you can see the different breakdown of the ages. We're most interested in the young group, the 10 to 24 group. Histograms make you feel like things are happening that aren't really happening. Histograms are archaic and useless in the days of Excel and advanced mathematics. There's no reason for histograms. Yeah?
So this is for actual suicide?
These are completed suicides. Yeah. So completed suicides year by year, that graph looks oddly similar. It looks like what you might see bacterial growth on a plate. It looks like what you might see in terms of world population. Exponential growth, and then exponential slowdown. So you can see that an 11-year-old has double the risk of a 10-year-old, a 12-year-old has double the risk of an 11-year-old, etc., etc. Overall, we express rates of suicide in number per 100,000 per year, and you can see that the highest risk group, the 22 to 25 group, their risk of suicide is 20 per 100,000 per year. So despite those numbers and those graphs showing you how common suicide is relative to the deaths by other reasons, suicide is still a rare event. If you just saw children randomly without looking for any specific risk factors, it would take you about 10,000 children a year to have one suicide. At age 10, it's the 10th leading cause of death in children. By age, I don't know what happened to that. By age 14, it's the second. So it doesn't take long for suicide to become the most important thing in youth. Next, accidents. The subcultures that we worry about specifically, you're always going to hear, and it's a great exam answer if you're ever quizzing someone on this, a medical student or someone that you have with you. Aboriginal people, especially young people, are at risk for suicide. That's not true in metro populations. So in metro populations, Aboriginal people have the same risk as non-Aboriginal people. It's in isolated, more reserve communities that we see a huge separation between Aboriginal and non-Aboriginal youth. Street youth and street culture, we should really be studying this here in BC. We have Canada's slum in the downtown east side. This information comes out of the University of Montreal, though. Stephen Huang estimating that approximately 10 to 15 times the rate of suicide in street youth, which doesn't surprise me. I would imagine that street youth is a much higher risk of suicide. GBLTQI2S, and the list will continue to go on and on. About 3 times the rate of suicide if you have an alternate sexuality versus people who are traditionally heterosexual. There's a lot of media controversy about bullies, thanks to a couple of very prominent suicides. What I will say is, as physicians, we are not supposed to be judgmental, and we know for a fact that the bullies are just as likely to be at risk for suicide as the bullied. I've never met a bully who has gone into the life wanting to hurt other people. They usually come from pretty bad environments, pretty bad social situations, and if we wanted to stop bullying, we would attack the things that set up someone to express themselves in such an externalized way. So those subcultures we worry about. In terms of risk factors of different illnesses, mental illnesses, the advocacy groups will always give you this stat that 90% of people who died by suicide had a mental illness at the time of their death. That's totally not true. The stats will show that, and I'll dissect why that's wrong. What we know is that mental illness adds risk. It is not a requisite for suicide. Mental illness is not the pathway that people die by suicide. Mental illness is a risk factor that significantly adds to the risk of suicide. So all mood disorders, most depressions that come through your office, whether they're child or adult, about 1.8% times the risk of suicide than the general population. If you add, or 1.2% lifetime risk, which is about 6 to 7 times the rate of the general population. If you add all mood disorders, including bipolar disorder and everything that happens to people for mood, it becomes 2.2. And that's greatly held down by the fact that most mood disorders are office-based mood disorders. Most mood disorders are, hey doc, I'm not feeling happy right now, I'm having some struggles. You try some treatment, 4 weeks later, things are a little bit better. That's the majority of most mood disorders. And one of the reasons that you might have heard that depression is much more strongly related to suicide is because psychiatric samples are tertiary referrals. So these are people who've been through primary interventions and 1 or 2 medications, and then they're referred to psychiatric clinics. And of course, they're more complicated with higher risk. Every textbook you see will say that 10% of people with schizophrenia will end up dying by suicide. That number is a multiple of 2 in terms of an overestimation done by bad math. And the takeaway is doctors should not do math. Leave that for the mathematicians. So it is 5% lifetime risk in schizophrenia. And actually, the longer you survive with schizophrenia, the less likely you are to die by suicide, which was the big thing that the doctors that originally said 10% didn't realize. Bipolar disorder is by its nature a more severe mood disorder, and it's a 6% lifetime risk. So, about 1 in 17 or so will end up dying by suicide. Lifetime risk of addictions in terms of suicide is very hard to tell because people who die by suicide and addictions die by overdose, and determining intent in overdose is a very challenging thing. It's one of the harder calls in pathology is how did someone die of overdose? So we think it's about 8% lifetime risk, but we're not sure. Eating disorders is often neglected when talking about suicide. It is the mental health disorder that has the strongest association with suicide, both in youth and adults. So you're 40 times more likely to die by suicide if you have anorexia than if you don't. But it's often forgotten with respect to schizophrenia, mood disorders, anxiety disorders, things like that. And there are libraries on borderline personality disorder. It is the psychiatrist's favorite condition. It goes all the way back to how we all love to imagine ourselves as little Freuds guessing at the causes of things. But despite all of these volumes of textbooks, the same people that are into all that Freudian stuff are not really that great at science. So we don't have a lot of numbers. So you would think with textbooks and textbooks on borderline personality disorder, we would at least have a grasp on the number of people who die by suicide, and we don't. We can estimate that about 5 to 10% of people with severe borderline personality disorder die by suicide, and that's all we can say. We don't actually have hard numbers. Suicide work, the reason I'm a suicidologist is actually I don't believe in the whole doom and gloom thing. I think there's actually lots of stuff that we can do. In the last decade, suicide rates in youth are significantly down. You can see that it looks to be relatively generational. Suicide rates are almost 25% down in the last decade in youth, about 20% down in the next bracket, and then fairly equivocal in the middle ages, and as people get older, the rates are increasing. So were this a presentation by a geriatric psychiatrist, there might be some insight as to why there's alarm in geriatric populations. I don't know what the answer is, and it's not my focus. What I can say is that for youth, things are definitely getting better. Most of that is a reduction in the male suicides. So for whatever reasons, boys are killing themselves about 30% less than they were 10 years ago in Canada and the United States. Are people who commit suicide mentally ill? And this is where I have to pull back and get a little bit philosophical. This is not science, but it's fairly natural to assume that people suffer before a suicide. But I define a mental illness as something that I can detect, treat, and would want to treat. So the things that I would require for a mental illness is somebody has a major dysfunction in their life. That would compel me, maybe I should try and modify this. So let's imagine someone loses their job or is struggling with their relationship or can't handle school or is having difficulties with their family. That to me would be a disorder. That would be one of the requirements of a disorder. The other thing is it couldn't just be transient. It couldn't just happen that day. They'd have to come to me and say, this has been happening regularly for a couple of weeks or maybe a few days consistently. I've been really struggling with this lately. If they came in, coming off the street is, an hour ago I just got really sad. It hasn't caused me any problems yet, but I just got really sad. I wouldn't call that a depression. I wouldn't say you're depressed, and I wouldn't say here's an antidepressant. I'd say, hey, do you want to talk about this? Let's set up an appointment. I'd try and figure out some things, but I wouldn't label that a mental illness yet. So it's really important to think about mental illness as a diagnosable, relatively non-transient, significant impairment in someone's life. And when it comes to that, there's these studies that say 90% of people who die by suicide have mental illness. These are called psychological autopsies. And there's a lot of research into them. And when I describe them to you, you see why they're so scientifically ridiculous. What they do is they phone family members 1 to 10 years after someone died by suicide, and they ask the following questions. Do you think your family member was sad? Do you think your family member had problems sleeping? Do you think your family member had problems drinking? Do you think your family member had problems with anxiety? Confirmation bias, attribution bias. Poor historians 1 to 10 years after a suicide. It's hard to get eyewitnesses to remember things 3 weeks after an accident. It's really important if you're doing psychological autopsies to control and blind. And sure enough, when you control and blind, you do this by not telling the researchers how someone died. You set up a control group of people who died unexpectedly. You hit them very early after the death, within a year. And you don't tell the researchers. The researchers collect the data, and then the people that analyze it don't look at it. When you do that, and there's been a recent study of youth who died by suicide, with the control group being car accidents, the rate of mental illness in suicide victims plummeted to 25%. And this is probably more accurate for what we see. Only 15% of youth who die by suicide have ever been hospitalized. So if our answer right now is let's send people who are suicidal to hospital, this is the result. 85% of people with suicidal thinking are still dying. Okay? Only 30% of people who die by suicide have been identified by anybody in their life as having a psychiatric issue. A single person suspecting that there was a psychiatric issue, 30%. So again, if our pathway is, let's wait until someone's worried and then go investigate it, we're going to miss 70% of the suicides that happen. So mental illness does add a risk, and it's a significant risk. It can be anywhere between 8 and 40 times the risk of suicide. But that turns something that's very rare into something that's slightly less very rare. It's not like everybody I see, 100% of the patients I see have mental illness. But I have yet to have a patient die by suicide. So mental illness is not a risk factor where you hang your hat on and say, this person's sick, I need to do this. We need to treat mental illness to reduce the risk of suicide, but that's not going to be the largest intervention we do, because we're already treating the mental illnesses we see. Psychiatrists already do this, and yet 85% of the people who die by suicide have not been hospitalized. Motivations for suicide are important to consider, and were this a longer lecture, I would have given you a pretty cool summary of why people die by suicide. What I will say is that understanding, not just that when I ask why someone wanted to die by suicide, they came into the hospital with an overdose of something, I'm not asking what was the fight about. I'm not asking who yelled at them. I'm saying, why did they want to die? What was the motivation of the death? Did I want to feel better because I was feeling crappy? Did I want to stop feeling something because I don't know how to make myself feel any better? Have I been thinking about this a while because life sucks? Do I feel like I'm related to anybody? Do I think I matter? Do I think that people would be better off without me? These are actual motivations, not I got into a fight with my family. That's not an answer to why. That's an answer to what happened. So understanding a motivation, and it's a simple question, what did you hope would happen after you died? How would this have helped you to die? What would this have done for you to die? These are fairly simple questions. You can actually target your treatments fairly well, because if they say something like, I didn't know what else to do, well, that's the person that needs a lot of psychoeducation on what you can do in crisis. If they tell you, I knew exactly what I've been doing, I've been planning this for weeks, then you know you need to fix that person's life or they're going to die by suicide. Someone with ALS isn't looking for a list of stuff they can do in crisis. Fix my ALS or I'm going to die, right? You have to fix the problem. Fatalistic motivation doesn't need a suicide safety planning list or things like that. So understanding motivation is very important. But there's another motivation that you have to consider, which is no motivation at all. Most of the children I see at BC Children's Hospital that come into the emergency department have no intention of dying in their suicide gestures. None whatsoever. 5 pills of Tylenol. Call their family. Call their boyfriend after threatening to hang themselves. Things like this. This is not a suicide attempt. There was no intention of death. It's a suicidal gesture. What we call that is non-suicidal self-injury, and it's behaviors or attitudes that appear to an observer to look suicidal, but actually are driven by another motive. So therapeutic cutting, trying to get attention, all these types of things. Therapeutic cutting is definitely on the rise, and I want you to always marry those two words. Therapeutic and cutting. Okay, it's really important that you see cutting as therapeutic. In 1991, 18 girls will have tried cutting by the time they've graduated high school. In 2010, 1 in 2 will have tried cutting. We also, as clinicians, need to normalize cutting. We freak out when we see a cutter. We figure, what do we have to do? This person's going to die by suicide. Yet I want you to all imagine someone coming into your office at 16 and saying, when I was 14, I tried marijuana. What would that change for you clinically? The answer is literally nothing, because we've normalized marijuana use. Yet only 38% of girls, by the time they graduated high school, have ever tried marijuana. 50% have tried cutting. So we can't therapeutically freak out when somebody cuts. Trying cutting is a relatively normal thing to do now. It doesn't mean it's okay. It doesn't mean there's distress. There aren't targets. There's lots of targets for us to attack. But we can't therapeutically lose it when someone cuts, because 1 in 2 kids do that by the time they've graduated, have at least tried once. Most people who try once don't continue. And there's actually lots of biological reasons why people cut. And I can't go into them because of time. Cutting is not a suicidal behavior. Every time I talk to someone who cuts, I ask them, what does the cutting do for you? It's a very simple question, and you can try it with anybody you know who cuts. They will not tell you they're hoping to die by their cuts. They'll never say that. If they do, they're lying. Because nobody thinks that a superficial cut will kill them. Nobody thinks that unless they have very significant intellectual disability. So when people are cutting, they're trying to do something. I want to feel pain to ground me. It makes me feel real. It distracts me from my problems. I feel more relaxed after I do it. These are all therapeutic things. And what I summon to help me with my empathy is, that's the best they can do. That's kind of sad to me. I want to help them, but that's the best they can do. Non-lethal suicidal behavior, so NSSI, non-suicidal self-injury, it's very hard to quantify because studies on attempts define attempts all over the place. There was one study that said talking to your counselor about a suicidal thought is an attempt. Well, what do we do with that science? That's one of the landmark studies on suicide attempters and their characteristics. And they define an attempt as someone who talks to their counselor about suicide. That's not an attempt at all. That's very, very helpful that they do that. I might want to know what's the difference between the people who talk about it and the people who don't. That might be a little bit more important to me. So I can't give you really hard numbers. What I can say is kids think about an attempt, make non-attempts, self-injurious gestures very, very frequently. The estimation is about 16% of adolescents will try a self-injurious behavior overall with the intent of making themselves feel better or in a suicidal gesture. In young females, this could be as high as 1,000 to 1 to non-suicidal self-injuries versus completed suicides. So it's far more likely for a female to do something that's quasi-suicidal or appears suicidal than to actually die by suicide. So there's a great research study done every about 5 years by the McCurry Center. They send these survey questions out to youth in high school and they actually capture a very impressive population, 29,000 students in BC. So this is very relevant to the type of work we do all the time. And they go all over BC. They do not just metro base it or anything like that. They make sure that the population in the study represents the population. The only caveat being these are school-attending people. So if anything, these are conservative estimates because people who won't attend school are more likely to have significant problems. So these may be conservative, but they ask questions on stress. And the bottom answer in the stress question is, it's like a little bit of stress, no stress, some stress, a lot of stress. So much stress, I can't function. 1 in 7 adolescents select that option between grades 8 and 12. Despair, a little bit, none, some, a lot. Last one is so much despair that I wonder if anything is worthwhile. 1 in 17 adolescents think this. If you plot that out by grade, you can see that a significant portion of our population has significant, not just a little bit, not just a lot, not just mostly. They selected the most significant stress option possible, the most significant despair option possible. Now, they started at age 12. If you follow this graph, you have no reason to believe that age 11 is 0%. Age 10 is 0%. Age 9 is 0%. You can follow that graph and you can imagine what it does. It likely exponentially comes down and starts plateauing at around 2 or 3%. So this computer-based survey was very cool because if you selected that most severe option, it said, hey, have you talked to anybody about this? And if you said no, it would say, why not? And these are the reasons people selected as why they haven't sought help for these problems. And I don't have the time to go through them, but they're all passive reasons. If our pathway is waiting until we're worried about someone, or waiting till they tell me they're suicidal, you are going to miss the great majority of people who have significant stress and despair who think these things are going to happen if they mention it, or worried about these things. They're not going to tell you. You have to ask them. A proper set of screening questions can be brief, it can be gentle, and everybody can do it. There are 13-year-old suicide volunteers on hotlines in Manitoba. So I'm very confident in family practitioners being able to screen for suicide. And it's necessary. You're 7 times more likely to get a positive answer if you screen for suicide than if you wait for a passive report. 7 times more likely. For every child right now you know about that's telling you about their suicidal thinking, there's 7 that have it and will tell you if you ask them, they just haven't said it. That's a very, very important number. So this is how I screen about it. I have the document on the website, goes over the rationale of why I've chosen these things and the importance of it. So I just say I'm going to ask you a few questions about your mental health. Do you think you've been under a lot of stress lately? Have you been feeling hopeless or sad about the future? In the past month, have you had any thoughts about harming yourself? Or have you done anything to end your life? Very easy to roll into that. Nobody's going to be taken aback by that. Nobody's going to be shocked that you're answering. And you should do this for everybody over the age of 10, period, if you're worried about suicide. If you're worried about stress and despair, which I think as a good clinician you should be, you should probably ask this of every child. Just skip the suicidal question because it's very unlikely for people under the age of 10 to die by suicide. But you'd probably want to know about stress and hopelessness. Very easy to do. I ran through those questions in, according to my thing, 16 seconds. I don't think this adds a lot of time. And if someone were to say, yes, I have a lot of stress, and then say no to both, you might investigate that a little bit further. It might be a little bit of piece of rapport for you with that child. It might get you a little bit of insight into that child's world. So what is a risk assessment? Say we do that screen and they say yes. What do I do then? This answers that question about what happens in the emergency department when I go down to see someone and what leads to somebody getting admitted or not. I do what's called a risk assessment. A suicide risk assessment is not a prediction of who's going to die and who isn't. I'm going to explain why that's so important. Because I send people all the time. I was on call last night. I sent 2 people home who was telling me that they had suicidal thinking. I admitted one of them. So I'm not predicting that the people that I send home aren't going to die by suicide, and the person that I admitted is going to die by suicide. That's not what I'm doing when I do that, okay? And this is why. Best case scenario, I'm on call last night, and a 15-year-old Asian female presents. No family history, no problems. They have a 3.5 per 100,000 chance per year of dying by suicide. So 1 in 28,000 that I see like that will die by suicide. So a pretty low chance that that person before me is going to die by suicide. I can feel relatively safe. Worst case scenario, 18-year-old schizophrenic male comes in with a strong family history. Everybody in their family's died by suicide. Everybody in their family has a strong personal history and lots of abuse throughout their life. They have 142 per 100,000 per year risk of suicide. And this is an estimation based off of some risk factors. That's a 0.14% chance that this year they'll die by suicide. 1 in 700 like him will die by suicide. So I can't predict if he's the 1 in 700 or if he's the 699 in 700. And I can't predict if she's the 1 in 28,000 versus the 7,999. I can't do that. They're all low-risk events. All of them are low likelihood. All of them are very unlikely to happen. On the CAPE unit, we admit 400 children a year with the most severe psychiatric issues in BC, and we have yet to have a suicide. It hasn't happened. We've been running for 10 years. So 400 kids a year, 10 years, the most severe psychiatric illness, 0 suicides. So this is not something where we're predicting suicide. We can't do it. And again, if you sort of do the math, we've only seen 4,000 kids. That's, even if it was, the only way we would see a suicide in that group is if the risk was as high as 400 per 100,000 per year. Sorry.
I just want a quick question. If a child comes in and gives you a specific plan that they have for committing suicide, would it be malpractice not to admit them?
No, not at all. No. Admission is not a treatment for suicidality. That's a horrible treatment for suicidality. I'm going to go over what a risk assessment is. So what I use is the 4 C's, which I've actually stolen. I don't know who I stole it from, because everyone else on the internet stole it from the same person. They didn't credit it. So I have no idea who's the original and who isn't. Collateral history is important in assessing suicide risk, and it's going to feed into your confidence. The more people you can ask, the better. In children, it's particularly important, because children distort things. Children aren't that accurate with respect to time, or the reactionary nature of children makes things a little bit less reliable. So the more people you can get, the better. I'm aware of the dietitians. Confidence. It's going to be fed in by your collateral history. It's also going to be fed in by how well you know the patient. If this is the first time you've ever met them and they're telling you they want to die by suicide, you're going to be much more worried than if they've been talking to you about their suicidal thinking for 3 years and they come in and saying that they're having a suicidal thought. So confidence is going to make a big difference on your suicide risk assessment. It's not a contract for safety. Actually writing the phrase contracted for safety is the same thing as writing means nothing at all. Okay? Contracting for safety has no validity whatsoever. The only way to do a contract that makes sense is to say, if you want to have a suicidal thought, promise you won't do it and call me anytime and here's my phone number. That would be a legitimate contract. That's the type of contract that DBT therapists enter into with their patients, and that's why DBT chose to reduce hospital admissions for suicidal thinking. You do not just ask someone to promise not to kill themselves, because they have a number of other promises before they die by suicide, including rent, cell phone bills, future appointments, going out with friends, things like that. Your promise will not have any weight if it doesn't have a consideration that you're offering instead. Poor engagement and rapport. If I go down to the emergency department and they say, I don't want to talk to you, well, my confidence in my risk assessment is pretty low. I haven't had a chance to talk to them. I might want to do that before I make a determination on how suicidal they are. I can't teach you common sense. What I can say is that you need to have it with respect to suicide, and that means walking through the day. The best thing to do when someone tells you about a suicidal thought, whether it was remote or today, what's been going on today? Tell me what happened when you woke up. What happened when you went to school? What happened when you fought with your friend? What happened when you got home? How many Tylenol did you take? Why did you take that Tylenol? What happened after that? Because if they told you that they took 10 Tylenol and then called their mom right away, there's a very low chance their intention was to die. If they took 40 Tylenol and waited to see you 3 days later, there's a really good chance that person needs a lot of intervention before they're safe. Active ideation is having a formed plan. Passive ideation is just thinking about it. So active ideation is far more likely to have risk than passive, about 7 to 8 times more likely to die by suicide with active thinking than passive. And I always want to ask people in the emergency department after they're there, well, you tried something and here you are talking to me. How do you feel? Like, it's a very common sense question. It doesn't really, like if they say I feel great or I feel bad, it doesn't mean one thing or another, but it helps me think about how they're thinking. It helps me feel about how reliable they are, and it helps me put things in sense. If someone takes 6 Tylenol and says to me they're really disappointed they didn't die, it doesn't make sense to me. You took 6 Tylenol. There's no way you could have expected to die from 6 Tylenol. It's not even possible. The big thing about admission is, do I have a changeable risk factor or do I have an unchangeable risk factor? This is the number one thing that makes me feel like I need to admit someone. Because if someone presents with a high age, history of schizophrenia, history of family illness, history of suicides in the family, they themselves have completed in the past, and I admit that person because they're so high risk, I'm going to discharge that person with all of those risk factors. None of them are going to change at all. I could admit them at any point in their life, and I could discharge them at any point of their life. And their chronic risk for suicide will remain as high as it's ever been. I'll have done nothing. But if they have acute suicide risk factors, access to lethality, an untreated disorder, whether it's physical or mental health, a recent crisis that needs dealing with, Lack of social supports. They don't have a family doctor. They don't have a psychiatrist. They're currently experimenting with addictions, or they're fully into addictions, or their family is fighting with them and it's not appropriate for them to be at home. I can modify that. There's something I can do. I can do that as an outpatient, and if I can do that as an outpatient, great. If I need to do that as an inpatient, this person has severe untreated bipolar disorder and they're very manic, I need to bring that person in. If this person has depression, I can start an antidepressant and get them referred to therapy and get them seen by someone within a few days. That's an appropriate treatment, as long as it's being followed up. So changeable risk factors that require hospitalization are what we admit. Without changeability, the only goal of hospitalization is to protect patients. This is the last myth that I really want to dispel. Hospitalization does not protect patients from suicide, period. People die in hospital in North America. About 1,800 people die in North America in hospitals every single year by suicide. The highest rate of institutional suicide is in prisons on suicide watch. There is no protection offered by monitoring or having someone watching or having someone next beside you. Suicide is a very simple gesture that requires almost no forethought and can be done in a heartbeat's notice. There is no way to physically prevent someone from dying from suicide. None. Even people who have been strapped to gurneys have died by suicide. You cannot guarantee safety by admitting someone to hospital. And hospital has no evidence that it reduces suicide risk factors. So I want to change something by hospitalizing, and I want to have something that I can modify by that hospitalization. These are a list of protective factors that also feed into it. And when I synthesize those things together, I review the risk factors, I review the protective factors, I take my interview that I had with them, I bundle them up together and think about what I'm feeling about their suicide risk. I consult with other people when I need to. I identify targets for my intervention, and I do those targets. It doesn't matter what you're doing as long as it makes sense, it applies to what they've done, and you've deliberated it. That's your only requirement for assessing suicide risk, is that you've deliberated it and you've analyzed it, not that you've predicted it. So there are tools available, and this was going to be in the presentation that's on the website. So there's a clinician rating screen that's great. There's the ASQ, which is, again, great. I have a document that is available on that website as well that helps you write down what you're thinking about suicide risk. It's a documentation tool. It's excellent. I'm biased because I created it, but it's a leading practice in Canada by Accreditation Canada. It's probably one of the best ways to document suicide risk that exists right now. So, and that's available as well. So I wanted to leave a little bit of time for the Q&A. It's a really big topic, so sorry I went a little bit over time, but thanks very much for your attention.